Thank you. I have nothing to disclose, so I'm going to go over mine in sort of a case presentation scenario. So you see a patient in your clinic, 50-year-old male, BMI 48, comes in for evaluation of bariatric surgery. You ask specifically about symptoms of heartburn, reflux, patient denies. And I think based on what Julianne was also presenting is how well do we trust that these asymptomatic patients actually do not have GERD? And so what we do know is that decreased esophageal sensitivity is associated with obesity. And in this study in particular, 138 pre-op bariatric patients, completely asymptomatic, underwent EGD, and 38% were actually found to have esophagitis or abnormal pH studies. And additionally, the symptom of heartburn in and of itself has a sensitivity of 29% at diagnosing GERD in the obese population. So I think when we think about those things and we have this completely asymptomatic patient that we're thinking, yeah, a sleeve or bypass is perfect for this person, how do you counsel this patient regarding their chances of developing de novo GERD after sleeve or gastric bypass? And so again, I think this study was also talked about by Julianne, but the SM-BOSH trial, published in JAMA 2018, randomized trial, this took place in Sweden, 205 patients randomized to sleeve or bypass. We had 5-year data on them. And then looking down here, we saw 32% of patients who were completely asymptomatic developed GERD symptoms after sleeve gastrectomy. And then 11% of patients actually developed GERD symptoms after Roux-en-Y gastric bypass. And then I think there's been a lot of studies looking at the rates of GERD after these operations. There's a lot of heterogeneity, mostly based upon how long you follow patients up afterward. But I think the results of at least 2 systematic reviews have found that de novo GERD after sleeve gastrectomy somewhere around 20%, and that's our best guess there. And then what we also see here, we also know that reflux can happen after gastric bypass for a variety of reasons, but it is obviously a lot lower when you look at the gastric bypass patients as whether or not they're going to develop de novo GERD. And so I think for an asymptomatic patient, yes, a sleeve or bypass is a fine operation to offer both, but whenever you're going to do a sleeve and you're talking about reflux, counseling that patient, there is a 20% rate of de novo GERD. So next patient here, this is somebody who, let's say they come to you and actually do have some symptoms of GERD and they take anti-acid medications as needed. Somebody you would classify as mild to moderate GERD. I think what you want to counsel this patient about, or what you need to know before you talk to them about what surgery you're going to offer, is what are the chances that her GERD symptoms are going to worsen or improve with sleeve or gastric bypass. And again, I'll go back to this study, the SM-BOSH trial, and in this patient population, that actually excluded patients with severe GERD or large hiatal hernias. People with mild or moderate GERD that were included in this study, remission of GERD was achieved in 60% of our Roux-en-Y patients, again, 5-year follow-up data, and actually 25% of patients after sleeve gastrectomy. GERD worsened in 6% after bypass, and 32% their GERD symptoms worsened after sleeve gastrectomy. And then this is another study. This was a bold national database based on bariatric centers of excellence. This was a lot more short-term follow-up. So most of these patients were at 6 months, probably at less than a year when they were looking at this. And this is patients who actually had GERD going in and what their resolution rates were. So what they found here, I think 62% of patients would say that their GERD symptoms got better, and this is gastric bypass. 84% of sleep patients actually said their GERD was the same. And then they had only 9% of sleep patients said that their GERD actually got worse. Again, these are all subjective measures of GERD, and again, this was a 6-month follow-up as opposed to our 5-year follow-up with the SM-BOSH trial. And then looking to what we have for systematic reviews and meta-analysis, I actually think there's so much heterogeneity in looking at sleeve gastrectomy, i.e. what kind of bougie size did they use? Did they repair hiatal hernias at the time of their operation? But I think you can see here, it's a kind of a 50-50 shot. 19 to 37% your GERD symptoms will get worse after sleeve. 20 to 40% they'll get better. But I think what the real story is here is what we know is that the gastric bypass, pretty steady, 68 to 80% of people are gonna say their GERD symptoms are better. And very little of them are gonna say things get a lot worse afterward. And so I think what else your patients are gonna wanna know is if their GERD symptoms get bad, how bad does it get? Okay, so how many of these patients are actually gonna go on to need their sleeve converted to a bypass? Meta-analysis data, this was published in Annals of Surgery in 2020. So they estimated that conversion of sleeve to bypass for refractory GERD, 4%, which may seem low to some people, especially if you feel like you do this a lot in your own practice. And then I think, caveat here, again, this Esophagitis trial with 5-year follow-up data, which is the longest of a lot of studies, they had a rate of about 9% of patients with refractory GERD undergoing sleeve to bypass. So again, take-home point here, I think a patient with mild to moderate GERD, it's okay to offer a sleeve to that patient, as long as we talk to them about what are the outcomes, right? About a third of those patients may have progression. The majority of patients will have improvement in their GERD after bypass, and then less than 10% of patients will ultimately go on to require another surgery for GERD. And I think that any of you people who do bariatric surgery here would know, I think when I start to talk to the patients about their reflux and the chance they may need a bypass, if you said less than 10% may need this conversion, this doesn't tend to make the patients want to not do a sleeve. Okay, next patient here. So let's talk about a patient who takes a daily PPI for their GERD, has a pre-op EGD showing grade C esophagitis. What kind of surgery are you going to offer this person? So what do we know about the effects of bariatric surgery on esophagitis? So this was a retrospective study, 227 patients. They looked at all of these patients had esophagitis prior to bariatric surgery. What they saw here, you can see the rates of esophagitis in people who chose the gastric bypass were a lot higher. But erosive esophagitis actually decreased 54% to 26% after gastric bypass, and this was 1-year follow-up on their EGDs. And then we had this cohort of 7% of patients that had esophagitis underwent sleeve, and you can see here they progressed from either their esophagitis went from a grade A to grade B or C, or they just developed de novo esophagitis. So progressed from 7% to 30% after sleeve. And this was actually published in Surgical Endoscopy earlier this year. So we had 54 experts in the field of bariatric and metabolic surgery were asked this question: if sleeve gastrectomy is an acceptable option for patients with severe GERD who require daily medication, if that patient can commit to lifelong endoscopic surveillance. And the majority of people, 83%, actually said no, they don't think sleeve is a good operation for somebody with severe GERD. And then what do we see with the effects of gastric bypass on esophagitis? So this study was done, 64 patients, 55 of which had erosive esophagitis, 9 had Barrett's esophagus. Majority, as you see, grade A or B. And this was, again, 1-year follow-up, EGD. After gastric bypass, 80% of patients had resolution, and then only very few of them actually got worse. And they also saw that the Barrett's esophagus rates resolved or improved, 75% in short segment, 40% in long segment. And then if you're wondering what the ASMBS position on this is, they agree that people with conclusive evidence of esophagitis, severe GERD, are better served by a Roux-en-Y gastric bypass rather than a sleeve gastrectomy. So again, take-home point here, I think if you have a patient with severe GERD and esophagitis, the recommendation would be not to offer that patient a sleeve and instead offer them a gastric bypass. And then last of all, our last patient, we'll say 60-year-old male, BMI 45, takes twice daily PPI. Pre-op EGD shows Barrett's esophagus, no dysplasia. I think you'll be hard-pressed to find many people who would sign this person up for a sleeve, and I would think the data actually supports that because there really aren't any studies looking at pre-op patients with Barrett's who then get a sleeve, and we look at the progression. And so this is the results of a systematic review and meta-analysis of patients who had Barrett's esophagus and underwent Roux-en-Y, 1-year follow-up data, or at least 1-year follow-up data. 56% had regression of their Barrett's esophagus. And then, like I said, to date, nobody's really looked at this in the sleeve, and I think there's good reason for that. Again, this meta-analysis, like I said, published in Annals 2 years ago. They looked at the long-term studies demonstrating the rates of Barrett's esophagus after sleeve gastrectomy, and they put that as an 8% rate of developing that after sleeve gastrectomy. Now, there are some critiques of these papers, and especially in variability in Barrett's biopsy technique, and maybe we're overdiagnosing this. But that is the data we have. And I think it's also important to take into account, right, that the overall progression from Barrett's to esophageal cancer is very low, 0.5% per year, and can be minimized through endoscopic surveillance. And there are no studies demonstrating that the incidence of esophageal cancer after sleeve gastrectomy is higher in patients than undergo Roux. In fact, the studies would actually say there is more incidence of esophageal cancer in Roux-en-Y patients for whatever reason. So again, severe GERD, Barrett's esophagus, I think we should recommend a bypass to those patients, mostly because we can see that it's a really good reflux operation and it's improving and their GERD and regression of Barrett's, and there is no data on what the effect of the sleeve will be, other than we know that it can increase rates of GERD and esophagitis afterward. And so I'll end this talk with, I think, you know, this is a talk over reflux and how it relates to gastric bypass and sleeve, but the effect on GERD is not the only outcome of importance when we're deciding what operation to give our patients. There are a lot of patients out there who may have reflux and are terrible candidates for a Roux-en-Y. And I think that thinking about their comorbidities overall, what's going to kill them first kind of thing, right? Is it a progression from GERD to Barrett's to esophageal cancer, or is it going to be their diabetes, heart disease, and things like that? So that's all I have.